Alrighty, so I'm always going to talk about Chapter 12, which is the control of normal mobility. Remember, the overall theme of this class, or any class, is you always want to learn normal, so that when you see a patient or an athlete that is abnormal, or the gait pattern is not normal, then you can say, okay, well that makes sense. But if you don't know normal, then how can you point out abnormal? You might just think, oh, they're walking fine. So before we get into it, let's talk about mobility. Mobility is the ability to independently and safely move oneself from one place to another. And that could mean walking, that could be sit to stand, that could be rolling, that could be climbing stairs, there could be a lot of things. So mobility is just not gait or walking. Our goal in rehab, regardless of their diagnosis, is rehabilitation goal of the treatment is to help patients regain as much independent mobility as possible. Okay? Now, mobility fits into one of 9 domains within the activity and participation component of the ICF framework. So I'll give you some examples of other mobility activities, but they could be sit to stand, climbing stairs, rolling, supine to prone, etc. And the gait pattern is represented in body functions and structures and component because it is one of the most important factors as when it's related to the health condition or disease. So if you look at this right here, you see mobility, and mobility plays a key role in activities, participation in the community, etc. But gait also plays its own individual role in the way that the body functions and the structures function. Because if you're not walking, well, then your body's not functioning and the structures associated with it can go down as well. Okay, so gait is extraordinarily complex, involves the entire body, and therefore requires coordination of many muscles and joints. Navigating through complex and often cluttered environments requires the use of sensory inputs, vision, somatosensory. I mean, it's just unreal how complicated walking is, and then we don't really realize how important it is until we can't do it. Okay. So locomotion itself, in order to be successful, you need to be able to progress. Okay, so what is progression? Progression is ensured through a basic locomotor pattern that produces and coordinates rhythmic patterns of muscle activation in the legs, trunk, and arms that successfully move the body in the desired condition or direction. Okay. Now the second thing is that postural control. Postural control involves the organization of multiple systems in the body to achieve both orientation and stability. Orientation involves aligning body segments relative to one another and the environment to achieve the requirements, and stability involves controlling the center of mass relative to the moving base of support and includes, well, 3 things, and we've talked about this: steady state, reactive, and anticipatory balance. Okay. And adaptation is basically the ability to adapt to your environment, right? So can you adapt to uneven surfaces? Can you adapt to rainy weather, walking on the beach, carrying something heavy? So that is important as well. Okay, so when we look at that, let's focus on gait itself, and then we can look at other forms of locomotion and mobility. But let's look at gait as far as the stance phase and the swing phase. So here's the gait cycle in a nutshell. Here's 100% the gait cycle, and here we look at the right leg. And so here's initial contact, which is heel strike. Okay, and then you're going to load. So loading response, that's 0 to 10%. Okay, and then you're going to have mid stance, which is 10 to 30% of the mid cycle stance phase. Then you have 30 to 50% of the terminal stance, and then we're at 60% at pre-swing. Okay, so that's the stance phase. Now, it's a good quiz question. 60% of the gait cycle is stance, and 40% is swing. Now, if you look at the gait pattern, let's say somebody has difficulty with heel strike. Somebody has difficulty with mid stance. We've got to say, well, what is it? What are the muscles involved? Why can't they heel strike? Is it because they don't have enough dorsiflexion? Why can't they push off? Is it because they don't have enough plantar flexion? What are the muscles that would be involved? And then what we can do is we can isolate that and start with just muscle strengthening there. getting the patient aware. Do they have range of motion? Maybe they don't have dorsiflexion. Maybe we need to get range of motion. So before we tackle the gait cycle, we need to know the basics. What is the reasoning why they can't achieve this? So if it's range of motion, we work on range of motion. If it's strength, we work on strength. So until you get range of motion and strength, we can't really isolate what's wrong with the gait cycle. This is should be a Y right here. Okay. All right, here's a nice little video you can look at to learn the phases of gait. Again, steady state gait, what does it look like in humans? Well, it's a symmetrical alternating gait pattern, right, left, bipedal, meaning both feet. And there's a phase lag of 0.5. So you're thinking, what is a phase lag of 0.5? So that means that one limb initiates its step cycle as the opposite limb reaches the midpoint of its own cycle. Okay? So thus, if one complete stride cycle is defined as time between two ipsilateral foot strikes, so right heel strike to right heel contact, right heel contact to right heel contact, then the contralateral limb, that would be the left, begins its midway through the ipsilateral stride cycle. Okay? So I'll show you what that means, like an example. But traditionally, all descriptions of gait, whether kinematic, EMG, or kinetic, are described with reference to different aspects of the gait cycle. So again, going back to what do we need for great locomotion? We need progression, postural control, and adaptation. And we spent a whole chapter on postural control. And postural control are in three categories: steady state balance, orientation stability when walking under constant velocity; reactive balance control, recover stability following unexpected perturbation to center mass while walking, right? So can you react to that? And then anticipatory balance control, activating muscles to counter destabilizing internal forces generated during gait cycle and destabilizing external forces. Can you anticipate the hole in the ground? Can you anticipate that the surface is slippery? Can you anticipate that there's a bunch of people coming towards you? Okay, so that with a neurological patient, those sometimes can be difficult. Now, locomotion, mobility, ability to adapt to the gait patterns, and then human gait, stance, and support versus the swing phases. So gait itself, like I said, we need to learn normal before we can learn abnormal. So here's the phases of step cycle. Here's the stance phase, 60%. Swing phase is 40%. So a faster gait speed requires more anticipatory control. Now you should know the difference between a step length versus a stride length. So a step length would be, let's say, left heel contact to right heel contact. But a stride length cycle would be left heel contact to left heel contact, or right heel contact to right heel contact. Okay, that's the difference between stride and step. So stance is divided into 5 subphases. You have initial contact, loading, mid-stance, terminal stance, and pre-swing. And the swing phase is divided into 3 subphases: initial swing, mid-swing, and terminal swing. And looking at these YouTube videos will help you visually see these patterns. Okay, so here's a great one that you can watch. Now, the way that we measure gait or document gait patterns is we use temporal and distance factors. So those are the things that So the way that we would document, like let's say velocity, they're able to travel 50 feet with a single point cane or front wheel walker in 2 minutes, right? And their gait speed is maybe 30% of normal. Okay, so those are some things that you wanted. Another thing you could report is they can walk continuously for 5 minutes. Right, so those are some things that we want to be able to document. Step length, right foot strike to left foot strike, that is the step length. You might want to measure that. You can just put, some water on your feet and go outside and just take a normal walk and then measure that, and you can measure your step length. and then you can measure your step frequency, which is the number of steps per minute. Your stride length would be right foot strike to right foot strike. You can measure that. Advantages of measuring step length versus stride. You can kind of see where the deficits are. So normal and abnormal gaits are often described with reference to these variables. Okay, so it'd be nice to see what your normals are. And here's something that you would need to know for the quiz. So the normal, for normal young adults, you basically walk at 1.46 meters per second or 3.26 miles per hour. Your mean cadence, your step rate, is about 1.9 steps, so 2 steps per second, or 112, 113 steps per minute. Okay, so the mean step length is of roughly 76.3 centimeters or 30 inches. So how do these variables vary as a function of gait velocity? Basically, you want to find out, so measure these for yourself. All right, so what happens when we start walking faster? All right, so what happens when people increase their walking speed? They typically lengthen their step and increase their pace. So although normal adults have a wide range of walking speeds, right? You see some people walking real slow, some people walking real fast. So I'll give you an example. My wife is 5 foot and I'm 6'1". So really I walk normal, but she's always saying, "Why are you walking so fast?" And I'm like, "That's my normal stride." She has to take 2 steps just to catch up to me, right? So she doesn't like taking walks with me. In fact, it has been found that in locomotion, persons comfortable or prefer walking speeds at his or her point of minimal energy expenditure. So you're trying to find the speed that you have to exert the least amount of energy. Okay, so why is walking energy efficient? Complementary motion at different joints minimizes vertical displacement of the center of mass, or smooth mechanical transfer of kinetic and gravitational energies. So when is gravitational potential energy of center mass at its highest versus lowest during the gait cycle? So those are some good questions that you can ask because they might show up on the quiz. Okay. So if you look at research has shown that during walking, the body vaults over a relatively stiff stance limb and that the center of mass reaches its highest point at the middle of the stance phase. So therefore, the gravitational potential energy of center mass is highest at the mid-stance phase. Okay. So in summary, the step cycle is made up of a complex series of joint rotations, which is, when coordinated into a whole, provide for a smooth forward progression of the center of mass and reduce the metabolic cost of walking. So if you look at this chart right here, right, so you look at the sagittal, sinusoidal, what happens at dorsiflexion, plantar flexion, internal rotation, extension, frontal plane, sagittal plane. Okay, so we want dorsiflexion and then plantar flexion, dorsiflexion, plantar flexion. Okay, that has to occur. When do we want, how much maximum knee flexion and knee extension do we need? How much hip abduction do we need? How much hip flexion do we need during the hip cycle? How much rotation, pelvic tilt, pelvic obliquity? Okay, so when you look at this stuff, you're like, okay, looks like I need at least 10 degrees of dorsiflexion and at least, about 25 degrees of plantar flexion to push off. Okay, foot rotation, a little bit here, but look at knee flexion. I need at least about 60, 70 degrees of knee flexion for the swing phase. All right, so here's the stance phase, here's the swing phase. So that you can understand that, okay, this is what I need. And if a patient is lacking that ability, we can say, okay, this is where we need to focus on. So a lot of information, hip flexion, of course, we need about 30, 35. Okay, so look at this chart and try to memorize this chart because it's good, and you'll be able to pick out normal versus abnormal relatively easily. Okay, so muscles in the stance limb support body postural control and propel it forward, progression. Muscle activity in swing limb occurs at the beginning and end of swing phase only. 2 goals to be accomplished during stance phase, that's postural control and progression. So make sure you don't fall and progress from one step to the next. So review some EMG patterns during the adult gait cycle in 12.5. And here's a great EMG Muscle Studies video that you can watch, and it shows you all the muscles that are active during walking. It's an excellent video. All right. Again, increased speed by cadence but requires more energy. Again, the net extensor movement, a variety of combinations can be used to prevent collapse. Balance during gait. Body in a continuous state of imbalance. Walking speeds affects center mass displacement. So if you look at the stance phase here, okay, so really looking at the joint angles, what do we need? Okay, what do we need at the hip? What do we need at the knee? What do we need at the ankle? It looks like the knee and the ankle are the key here for the stance phase. In the swing phase, well, we need a lot of things here. We need the knee, the ankle, okay? So if you had to look at the two main joints during a gait, you'd probably want to look at the knee and the ankle. Okay, so the major goal is to reposition the limb for toe clearance, right? So if they can't clear their toes, that's what they're going to basically fall on their face. And there are so many people with strokes that fall because they can't clear their toe. Now, adaptation of gait, reactive and proactive balance control. What we want to do is we want to say, well, adapting gait to changes in the task and environmental demands critical aspect of mobility in daily life, meaning is the patient able to adapt and to change direction? Now in the clinic we can't really reproduce all those crazy environments that they might say. They might have uneven terrain, they might have rainy, they might have snow. We really can't reproduce all that, and so we do the best we can. We see how they can adapt to different gait changes. How are compensatory automatic postural adjustments integrated into the step cycle? How do these differ from proactive strategies, subconsciously made or unexpected? How do we adapt our gait when crossing obstacles, changing the surfaces, adapting to inclines, turning? So the key is, and we talked about this already, is we're going to deal with balance first, and then we're going to deal with mobility. Meaning if you don't have balance, how are you going to be able to be mobile? So that's why in the first few chapters we learned about all the balance training that we can do. And now we're going to work on mobility. So control mechanisms for gait, spinal cord, and you have something they're called CPGs. They're called central pattern generators. Something has to move. There's descending influence, musculoskeletal contributions. Continuous interaction exists between the central pattern generators and descending signals from higher centers. Now, if you took anatomy already, you remember the spinal cord and the brain functions, spinal thalamic tracts, tectospinal tracts, all these tracts that go up and down, and it's like a super highway. Okay, so when there's damage to these tracks, unfortunately, there's going to be some difficulty getting that information across. Now, what is the adaptability of the human gait? So let's look at the brain itself. Here's the motor cortex, there's visual signals. Here's the visual cortex, which is the occipital lobe. This is the frontal lobe. Here's the cerebellum that does posture control, equilibrium, and then we have our brainstem. So when you have an intact system, adaptable locomotor control system to meet the goals of the animal in any environment. When you have a decorticate preparation, that's dynamic stability. So that's this right here. Initiates reasonable, normal, goal-oriented behavior in neonatal decorticate animal. And the decerebrate, which is right here, improved coordination of activation patterns compared to the spinal preparation, weight support, active propulsion. And then the spinal preparation right here is near normal, rhythmic activation patterns, functionality modulates reflex action, executes other rhythmic movements concurrently. So when you go here, if you go down the pattern, when they have an injury to the spinal cord, it's not as serious as if they have damage to the decerebrate, than if they have damage to the decorticate, and then if they have damage all the way up the chains, right? So a spinal cord injury is not as bad as a brain injury. I mean, they're both bad, don't get me wrong here, but as far as a rehab potential, something with spinal cord injury, we could help them recover or get back to some sort of mobility versus someone that has a frontal cortex or a stroke or anything that is a little bit more involved in the brain. Because you got to realize in the brain you have so many factors that are controlled, whereas the spinal cord, it's just usually leading to the muscle itself. But it depends on the lesion, it depends on the area, so don't get me wrong, spinal cord injuries are serious. Okay.